Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and this episode was recorded with the sponsorship and support of the Special Operations Medical Association. Thank you guys very much, and I hope you enjoyed the talk.
Process Services has trauma surgeons, emergency medicine, combat medics, and corpsmen. Also, with 25 SMEs, approximately 100 consultants. And so we bring in the smartest and the brightest that have been associated with the DoD for a while, from the likes of Rick Butler, Stacy Shackelford, John Holcomb, Bob Mabry. And so it's humbling to sit into a room with some of the brightest that have such a great historical perspective on where we started and where we're trying to get to. So COTC meets twice a year in person, and then also several times virtually throughout the year. And these are all part-timers too. So every one of these members has a day job of something that they're doing. And so the capacity to come together and then to knock out what some can consider, the baseline of battlefield medical competency can be a challenge. So TCCC guidelines, what are they based off of? So we do ongoing reviews of published civilian and medical pre-hospital trauma literature. That's where most of it comes from. Evidence-based medicine is at the forefront where the guidelines come from. Additionally, we have ongoing interaction with military combat casualty care labs. We get direct input from folks just like you that come back and give lessons learned from the combat corpsmen, medics, and PJs. We also get input from our SMEs and lesson learned centers. And then we also get case reports from the Joint Theater Trauma System and observations from the field. And that helps influence the guidelines, and then we put it into a format usually published once a year. Additionally, COTC also publishes abstracts. And so every quarter, we kind of flush through all the peer-reviewed journals that are out there that publish relevant stuff that you guys can find on deployed medicine. So it's a great location, free as long as you can get on to deployedmedicine.com to find highly relevant TCCC articles and at least the abstracts in there for your further research and intellect. So as we discuss stuff on the battlefield, this is Brian Eastridge's paper published back in 2012, which is really the forefront of, it was the guiding light, I think, of TCCC in this community to figure out where we need to put our focus efforts on battlefield medicine. And what Eastridge found, as all of you know, is that most people are dying in that pre-MTF environment. And what's the cause? It's hemorrhage. Truncal hemorrhage is high, junctional hemorrhage is high extremity. And then secondary to that is upper airway obstruction. So that's where the focus has been for the last decade, is improving those outcomes and then helping to reduce the mortality. And has it worked? It has. So if I can orient you to this graph, so on the left is the percentage of casualties, up the bottom is a timeline, and then on the very bottom you can see highlights of what's been implemented along the way. And that big orange graph that's going up, that's our ISS above 25 survival rate. It's skyrocketed. So it shows that what we've been doing is working. The focus efforts on battlefield trauma has worked. Along the way, of course, the blue line is the KIA percentage is going down, and the died along the way, and so is the DOW. TCCC curriculum, so 4 tiers of rolling care that TCCC focuses on. All service members was released back in 2019, shortly followed by the Combat Lifesaver, the Tier 2 in 2020. And then for our medical personnel, In 2022, the Combat Medic Corpsman, and then 2023, we released the Combat Paramedic Provider. That's our Tier 4. Where can you find the information that kind of encompasses why we should be using TCCC? Well, it's found in the DoD 1322.24. It's the founding policy that's out there. There's a lot of good info of when you should be recertifying and so forth. So this was updated in February 2022. So we're going to quickly go through the tiers. So all service member, that's for our BLS, our non-medical providers, those that may deploy but not really be outside the wire. These are the folks that, as it says, all service members. These are just some basic guidelines of what should happen if somebody is found in harm's way. And so focus on the 10 TLOs, the terminal learning objectives, and you'll see that will keep going up as we move into some of the higher tiers. So the CLS, the Combat Lifesaver, this is also for your non-medical providers, but those that are combatants that are going outside the wire, intermediate life-saving skills, and deployed. As you can see, there's a stark increase in the TLOs and ELOs. Moving on, Tier 3. This is for our medical providers, most notably our 68 whiskeys. You get advanced life-saving skills on scene medical personnel and point of injury care. And this is for every medic, corpsman, med tech will receive this, and the retraining windows every 3 years for Tier 3. And finally, Tier 4. This is meant for our advanced medics on the battlefield, our SOF, our paramedics, our flight medics. New target audience for this, in fact, is our medical officers, our docs and PAs and others that are working in Role 1 level of care. Not necessarily designed for every provider in the military, but focused on those that are going to be assigned to the Role 1 units who train and supervise combat medics. And so each of the tiers is a building block. There is no modification from one to the other. And so that's the beauty of TCCC. If you have a foundation in one of the earlier tiers, it builds up and there's no modification that as you gain competency. So what you can find on Deployed Med is the curriculum content that fully outlines how you can teach TCCC, learn TCCC, and ensure an enduring program. And so the great part about what has been built on Deployed Med is that there shouldn't be any excuse for having to go outside of what is built on Deployed Med to gain any type of resources. So curriculum, training aids, technology, and then course evaluation and so forth are all built into the year. Quick reference cards, video tutorials, etc. It's a one-stop shop to be able to teach and learn TCCC. Additionally, recently added TCCC Train the Trainer, including updates to the guidelines. So completely new addition to the Train the Trainer course, which requires recertification. So the course and expiry and certificate requires TCCC trainers to stay up to date with current and future changes in TCCC. And so where can you find this? I've already referenced this a few times as Deployed Med. So deployedmedicine.com, you can access it just via your browser, or you can download the app. It's available on iOS or Android. Highly recommend it. If your medics do not have this on their phone, they should. You can easily reference the guidelines, and then all the teaching material, all the student material is all located in one spot. What's also new on there are training and reference. JTS CPGs have now been included on there. Canine casualty care and prolonged casualty care has also been added. So truly a one-stop shop for your battlefield medic to find the guidelines and the teaching material and study material that they need to find. Also the news events and of course the journal abstracts are also located on Deployed Med. For those of you that hadn't seen this quote, this really rings true. This is kind of our guiding quote amongst the committee by Frank Butler. Nothing gets a pass because that's the way we've always done it. And so the way that I like to look at this is we don't look at dogma and then just go off of dogma. And I think every time that we look at like a guideline review or look at new ways of doing things, we don't just start with what we've done already. We go where the evidence tells us to go. And sometimes that can be challenging because the evidence is not always there. It's not always clear. And so luckily we've got the SMEs in the room, DoD's brightest to be able to interpret like what's right and what's wrong. Sometimes we have to stick with the dogma, but oftentimes if we have the evidence to show that we need to be going a different direction, we'll do that. And that's evidenced off the guidelines. All right, moving on. 2024 TCCC updates. So last year we published 2 updates. This is one that I did, and we made a robust change to the airway management guidelines in TCCC. We highlight the need when you place the patient in your recovery position to add also a chin placement of elevating the chin. We've also removed the chin lift and jaw thrust and removal of the extraglottic airway from the guidelines as well. We made descriptive indications for how to perform a crike. Since we're removing kind of the intermediary of the extraglottic airway, we want to ensure that people didn't go immediately to a crike, that they had specific indications in place. If they were going to perform that invasive procedure, they had a why. We added continuous end-tidal CO2 verification to the crike because we had found that often that our Tier 4 were doing the procedure, but not accurately being able to tell if they're in the right spot. We moved the MPA from the airway to the respiration section, and then also we added some snippets to the respiration section, including specific guidance on what size of VPN you should use, because we were finding that we were overinflating our patients. And then we also added continuous end-tidal CO2 guidance while performing the BDM. Additionally, Steve Rush led the TBI proposal change. We added TBI management to the tactical field care section. We added SpO2 guidance to prevent hypoxemia. We also added a guidance for preventing hypotension and then maintaining the blood pressure between 100 and 110. We added herniation ID management as well, and how to look at the patient in a declining neurological status with asymmetric or fixed dilated pupils or posturing to make sure that you're elevating the patient head and interventions for events. Also, we had guidance for the hypertonic saline and hyperventilation using end-tidal CO2. So what are we working on right now? So John Mehta and Chris Androsky are working chest trauma, Neil D versus finger thoracostomy, chest seals. Do we need chest seals? Can an open pneumothorax be okay? Or do we need to ensure that we put a chest seal over that and the efficacy of the vents on the chest seals themselves, the pros and cons of that? And then also de-emphasizing tension pneumo while also prioritizing treatment of hemorrhagic shock. And so this has been a great discussion on the committee, and we've got some solutions for that, which you'll see in some further slides. So when we go through these proposed changes, our guide is to ask some questions of things that we need to have answers to, and that should help kind of develop the guidelines themselves. So these are the chest trauma questions that the team has been tasked with, and will help kind of guide what the guidelines look like once we've answered up. We're also working hemostatic agents. This is Lorenzo Palladino's case. And so we're looking at all the objective comparisons between the products that are out there. These are the questions of the hemostatic agents that Lorenzo is looking at. We've also reviewed TXA dosing and routes. This was Chris Gonzalez and Britt Long. It was a relook at a pretty recent change, but there's been new data that's come out, and so we thought it was worth a relook. At this time, there doesn't seem to be enough evidence to make a change, but we're continually looking at evidence supporting the possibility of IM TXA administration. And here are the TXA change questions. Antibiotics and TCCC, this is Piotr Wisniewski. Selection timing, review of prior neutral results. Here are the questions tasked to the antibiotics. And this is the proposal that we have in place right now. These are proposals, so please don't go out there to start throwing out your invans just yet. These are not in the guidelines, but this is a proposed change right now that the committee is considering. Also, the committee is looking at addendums to the guidelines as well. So Remley and Jack Furr are looking at how we accurately and come up with a consensus on how we do triage. And so there are dozens of ways out there to do triage, and most of them are effective, but we don't really have continuity within the DoD on how we do triage. And so what we're hoping to do here is get a consensus from the committee on an addendum that will go not necessarily in the guidelines, but can be found afterwards on when you encounter a mass casualty, how do you triage your patients? And so their proposed inclusion will be published as a supplement and outline methods to conduct first and second pass triage, and then categorize the patient for treatment and then back. So based off of John Matha's chest trauma work and some of the questions that we had out of that, the committee is now looking at some possibility of March changes to prioritize treatment of hemorrhagic shock. I think the problem statement right now is that we have some treatments in place that are probably less urgent to getting blood on board. And so we're trying to correct that. We're looking at several COAs on how do we implement that and working inside the March algorithm. We've also talked about, do we need to change the March algorithm? What are the short-term and long-term effects of if we change March to, say, match or add an R to March, and knowing that there would be some short-term and possible long-term pain for that. But if we decide to do so, if it makes sense, if it's prudent, because it's based off of the long-term survivability of the patient, then we'll move out that way. But these are some of the COAs that we're exploring right now. We're kind of in the infant stage of this right now. But the goal is to ensure that we're providing the blood at a prudent time and making sure that that is emphasized and prioritized before maybe some less time urgent other treatment. Some additional working efforts that we're working on in TCCC, extreme cold weather. So COTSI is involved with the development of the JTS CPG on extreme cold weather casualty management. This is an area in which we know that March is changed to MH, ARCH, as hypothermia prevention, must immediately follow mass bleeding. Also, NPO is working pediatric TCCC, also as an addendum. These are some of the questions that we proposed to him, and then hoping to get a pediatric addendum out shortly. RDT&E. So COTSI has previously published R&D top 10. This go around, we're going to publish a top 10 for each of the research, development, testing, evaluation. We have a heavier focus on T&E, and this tells us which devices, products, and concepts work and don't work in the environment by the people you use them. T&E has been a huge gap in military medicine, and we're trying to influence and overcome that. Following casualty care guidelines published in 2021, the PCC working group transitioned to a standing subcommittee of COTSI. And we're hoping to publish guidelines for 2.0 coming soon. Rich, do you have an update on PCC guidelines? Yeah, it's up for a vote right now. So stay tuned for 2.0 guidelines. Let's get that one. All right, so how do we as TCCC grade our evidence? Because there's a lot of evidence out there that we gather from a whole bunch of different sources. And how do we ensure that the guidelines that we publish, that they're published with a good quality? So this is a scale that we use, a BCCHA methodology for that. And you'll find that when we publish the guideline changes in JSOMP, you'll find the evidence grading is included in there. COTC recommended. So codifying the committee's methodology for evaluating and recommending products. This is hard. So as I stated earlier, there's only 45 members on the committee, and they all have day jobs. And so just being able to get those guidelines out to you guys in itself is a pretty big feat. But the committee also recognizes that we have a gap. Like, we want to ensure that you're not going out there with poorly made equipment. But at the same time, the COTC doesn't really have the capability in-house to evaluate all those equipment items that are out there. So we know it's important, but the manpower involved in that and the resources is strained. So we're working on ways ahead to include a position statement and outlines based off data that's out there right now to be able to make recommendations, not necessarily approved, and so words matter. We've been careful as a committee not to use the word COTC approved. They're recommended items out there, and so we're going to continue to try to develop solutions on how do we ensure that you guys are using the best equipment. All right, this is the last slide. So these are the guys that make it happen. Travis Deaton is the chair for COTC, and then Monty is the program manager. He does all the heavy lifting in the background. COTC's out there, so you can find it all on social media, all over the place. YouTube videos, they're all out there. I would say if you need one-stop shop, go to Deployed Med. All the items that you're looking for are out there. With that, Rich, did I miss anything? Nope. Okay. Standing by for questions.
Travis. Van Hog here. Travis, thanks so much for filling the brief. Most importantly, also thanks for continuing this important line of effort. One small question for you. With all of these exciting updates to the tiers, I'm wondering what the back-end requirement is for being an instructor for those different tiers. I know that's been a concern from the operational force. Thanks.
I have that.
Ed, sir, great question. Rich Jarrett, I'm the program manager for all the curriculum. I really have the easiest job. These guys have to make all the tough decisions, and then we have to try to figure out how to implement it. Sometimes that implementation is like you said, pretty difficult. So you would probably think that implementation would be maybe the easiest part once we have a fully developed curriculum. But it takes a while to actually build up the cadre. That's probably one of the biggest friction points in being able to implement. We tried to provide further guidance. So back in December, we developed frequently asked questions on deployed medicine to help educate the services on what those minimum requirements are for how to become a trainer. And so since then, there's been great movement within the services and being able to look at those requirements, figure out a strategy on how to develop those trainers, and then promulgate those in policy. It does take time, as you're aware, sir, but if any of you are interested in understanding kind of where those requirements are on deployed medicine, there is an instructor trainer resources collection. And we posted the frequently asked questions there. So it'll be kind of really for all tiers what those requirements are.
Hey guys, great presentation. This is one of the highlights of the year. Hot topic, obviously, seeing the Ukraine casualties, tourniquet conversion or revision. Any changes or discussion as to what level and where that comes up in the training boundaries?
I'll take that one, Doc Keaton. So this is a great point. Last year, there was a change in tourniquet replacement and tourniquet conversion. Previously, it was only at the Tier 3 combat medic, corpsman, and higher level. They have since decided to move that into the Tier 2. So all Tier 2s have tourniquet replacement and tourniquet conversion. Curriculum has been updated to reflect that, and notifications were pushed out for that. So there are ongoing discussions on should that be pushed down to the ASM level or not. Those discussions are still ongoing, but yeah, right now CLS is where it's at.
This has been a tough one on the committee because what we found is that tourniquet placement often was unnecessary for a lot of those combatants, and so it's a training problem. And so if we find that those combatants are putting on tourniquets where it's not properly indicated, are we comfortable with them possibly converting when it's not indicated as well? And I think that's a large risk, but we also identify that the risk of keeping it on is large as well. So it's a training burden. And I think knowing like whether we can apply the proper training to our medics to ensure that they're putting them on in the right point in time, and also having the indications to take them off has been a challenge that the committee is trying to solve. And I know we've come up with several products to try to breach that gap, that training gap out there. But we recognize it's a gap that can be solved.
Yeah, just a follow-up comment to highlight that we're de-emphasizing some of the airway stuff. We're de-emphasizing the chest stuff because there's only so much time we have to train. And we saw Eastridge says, hemorrhage, things that we can affect. So as an education training side of things, I just encourage people to look at, if you train people to put on a tourniquet, train them to reevaluate and take it off, and maybe buy some time by spending less time doing all the stuff that prevents you from resuscitating with blood, right? So if you're a trainer and you only got 2 days, you just got to balance that type of stuff. So what's important is what's being re-emphasized, but also what's being de-emphasized, because you only got so much training time. So no, that's a great point. Thanks.
Yeah, Doc, and as a follow-up to that, you saw that airway proposal change too. The airway change, we de-emphasized the amount of airway work that's being done there. We've gone back to a lot of basics on the airway, and then we're looking to try to do that as well on the chest side as well.
What's up, Travis?
All right.
So a couple questions for you guys. One, when it comes to how we say recommendations and not the approved list, we need to be extremely careful on saying recommended for any product, whether it be a cat, soft tea, whatever, opposed to just saying, hey, the recommendation is something that's this size, does this thing. Because what had happened in Ukraine, they made their own tourniquets and knee tourniquets, phenomenal. However, all of their guys wanted cats, wanted the COTC approved recommendation, to the point that we couldn't get tourniquets in large areas of the world backward for exponentially long periods of time. How do you guys recommend fixing the recommendation versus approved list discrepancy?
Such a great question. And so this is something that Monty's actually championed himself on, whether we need to not necessarily come up with a brand names of what's recommended or not, but come up with a set of criteria. I think the challenge with that is that we may think at this time we know what those criteria look like, but there could be future products that come out that don't meet those criteria that are just as effective. And so we could go out there and say, what's say for a tack tourniquet, it must have a windlass on it, it must have a buckle on it, and it must be X amount of wide. But if a product comes out that is more like a stretchy strap that can go around that doesn't have any of those features, that is just as effective or more effective, then we've lost out on those particular items. I think you can get halfway there by saying, well, does it do what it's intended to do? And from that perspective, I think we've done that in the past, but I think for the end user, they're going to have that data to say, hey, does it do what it's intended to do, unless we publish something that says, hey, this did what it intended to do, so these are the ones that are recommended. So it's a challenge. So it's a challenge, Rick. And so we talked about this endlessly. I'm not quite sure how we fully broach it, because there is some manpower constraints there. But it's something that we talk about endlessly on the committee.
Second, with the discussions of rearranging March and to prioritize blood, 2 questions go into this. 1, do we think we're going to have blood on the front at a list of buyer? Second is with that currently in UCOM and lots of areas in Indo-PACOM, we don't have blood because the logistics mechanism peacetime doesn't support it. How do we get around?
Yeah, so we're out of time right now, so I'll keep it a little bit short. Sorry, Rick. We're done. No, I mean, the committee doesn't deal with logistics. But there's an assumption that blood must be there, right? It has to be there.
For adaptation, you have to look at logistics. Otherwise, we can't go with March already as prescribing.
Yeah. Yeah, and that's a great point, Rick. I think we've also broached this when we decided to add entitled CO2 to the airway change. We know that for a lot of units, it is trying to be able to go out and purchase some of those expensive units. And so we went back and forth on, do we add something in that's really hard for some people to get? And we felt it was a forcing function to go out there and get it. And so I look at blood the same way, that if we say... I'm sorry?
How long has blood been?
So how long is blood good for? And so I think...
After we supply all blood, every crew is at minimum. Right. Where I buy a car and Emma, that will suit you monitor, okay? It's just for as long as the battery.
Right. Yeah, I think...
It's a difference in just cheap. The backside to us is big.
Yeah, and so Rick's point is that right now the logistics train out there and the ability to keep it for prolonged periods is strained right now. It's not happening. I think from a committee perspective, we know that we can't own the logistics, but if we provide what right looks like, our hope and the desire is that the logistics will catch up to that and then provide the best quality of care for the patient. And I think from the committee standpoint, that's what we're hoping for. All right, that's all I got.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast, out.